Welcome to the 11 a.m. 5 Years Out panel for health communication. We have three scholars here who are going to share with us their vision of what is health communication, the evolution of the field, where we're heading, what we're doing now, some exciting areas. And I really want to take this as an opportunity for them to talk rather than give a big formal presentation based on their decades of experience here. So we have Gary Krebs from George Mason University, we have John Nussbaum from Penn State University, and we have Becky Klein, who is now at Kent State University as of just a couple months ago. So I want to welcome our panelists, and I want to say thank you for coming today. This panel evolved out of a need for a 5 years panel, and simultaneously the Coalition for Health Communication, which is a group you might not have heard of before, but probably, how many of you have heard of the Coalition for Health Communication? Yeah. So, and it's a group, and I think Becky will give us a better background regarding it. It's a group that spans ICA, NCA, and APHA. And so it's a great cross-disciplinary way of thinking about health communication because these folks are partners. I think I'll let Becky talk more to that. But as a group, I'm now the chair or president of the group, and I have a lot to learn for sure. But one of the tasks that we're doing is taking on a white paper. And when we originally put this together, we assumed we'd have this white paper complete, and it's not. We have some outlines, we have some pieces of it to really kind of place health communication within a larger context within public health, for things like the National Institutes for Health. What is health communication? What does it mean? And I think sometimes we struggle with identity, and I think it's wonderful for us to be able to place ourselves. So these folks are part of this white paper. There are also three other individuals who are part of the white paper, and that's Vish Viswanath, Leslie Snyder, and Pam Whitten. And so those three clearly are not here today, but we do have these three wise scholars for us to share. So I just want to start off with first, I want Becky to sort of give a little bit more information and provide some background about the Coalition for Health Communication because I think it's a great starting point for us.
Okay. Well, I'll tell you a little bit about the history because I think this may give you an appreciation for what we've tried to take on, and I think sometimes successfully, sometimes not, but we could be positioning ourselves to influence some pretty important issues that relate to health communication funding. For example, right now, the situation with the Center for Health Marketing at CDC, it's being closed. There's some concern about whether the communication functions will continue. The coalition could take a stand on that on the part of all three organizations if we choose to do so. This organization started when I began attending the American Public Health Association's Health Communication Working Group. And what I found was that was a very energetic group where young people ran almost everything. And there were some of us who were in ICA, NCA, who were part of that group, and he said, we need to be talking to each other. And they were very hungry for theory and research and to know what the researchers had found so they could practice it. And some of them also are researchers. And so they put me in this position to try to be a liaison among the three organizations. And what ultimately happened was that we had several years ago some program swaps where we promised to swap programs where NCA would promise a program to APHA and vice versa, and ICA. And we did that, and at that point we said, we're not getting together often enough. We should meet at the Kentucky conference, which we did. And at that point decided to try to form this sort of loosely knit network across the three organizations. Let me read to you the mission of the coalition. The purposes of the CHC shall be to strengthen the identity and advance the field of health communication. And I think what was happening was the recognition that the researchers didn't really appreciate the complexities of practice and probably needed to be accounting for some of that in our research, and the practitioners wanted to know more about theory and research. So we began the coalition in that fashion, and that was the history. Now, we haven't continued the program swaps. As you all know, it's become very competitive to have papers accepted at ICA and NCA, and it's also just about the same level of competitiveness for APHA. So I don't know that project can be picked up again, but we are looking at each group in terms of how can we begin working together. The APHA group has come up with some nice ideas for mentoring where we might include some of our researchers in mentoring projects We've talked about trying to link people in an informal mentoring, not that the mentors would spend a lot of time with them, but there was someone that a young practitioner could call and talk to and get some mentoring from. So that's a kind of project. That one's obviously not been enacted, but that's the sort of thing that we've tried to approach the larger issues that affect all of health communication. Does that
Great.
do what you want to know?
That's great. Yep.
Okay.
Yeah. So I think anything that you folks want to add to that? Okay, good. All right, we'll move on then. So I want to start with a couple of questions. We're going to take us through a little bit of background here with health communication and what distinguishes it from, say, health education and health promotion. And then we're going to take a look at, where are we right now, and then sort of moving forward. So we have that nice chronological order of things that we're going to follow here. And if you have questions along the way that you're dying to ask, please do. I think that we want to make this interactive too. So here's a question for the panel. Characterize the trajectory that health communication has taken from its early inception. What are our roots, and what has moved us to where we are today? And do you think there are any critical, pivotal time points in our history that have really brought us to the forefront? Yeah.
Can I back up just a little bit
Sure.
on the background to fill in? Because I think I jumped over something here that
Sure.
maybe you wanted me to talk about. And that was how health communication is similar or different from public health and health education. And I would say that as a discipline, we don't give ourselves enough credit. We don't realize what we know that other people don't know. And it's very basic. When I worked in a Department of Health Education and then subsequently at a comprehensive cancer institute, I really needed to learn to talk about health communication in a very basic way that could be done fairly quickly to characterize how we were different than health education. And we're different in some very significant ways. Now, that doesn't mean, and I'm sure Gary would jump in and say this, that people are doing health communication scholarship and practice from other disciplines, and they're doing it well. But there is a core to our discipline that we have built on from our very basic courses. And so I began talking about health communication as messages and meanings, that these were messages and meanings that were associated with health, that influenced health or were influenced by health and risk. And that became kind of the kernel of how I talked about it. And what we really need to be doing is trying to develop an identity that, as we all talk to people both within the discipline and outside of the discipline, that we have some agreed upon key ideas of how we want to present ourselves. And I think that's the vision of having a white paper, that hopefully we'll have a document where we can hammer out some of these agreements. But I think it's as fundamental as messages are symbolic behavior, and human beings act on the meaning of messages, and that messages are complex and they come in many forms. That meaning goes way beyond information, because I think a key distinction for us as a discipline versus health education, in health education, one of the fundamental premises is that you solve problems by disseminating information. And of course we do that in health communication as well, but we have an appreciation that messages go way beyond the denotative informational content of messages. And I tell people, I've actually said this at grant reviews at NIH, I said, you know this. You know that messages are more than the information. You were told that as a child. Somebody said to you, it wasn't what you said, it was how you said it.
Sure.
And you got punished for it. And so we know a great deal about framing messages, the complexity of messages, the levels of meanings, the various kinds of strategies and theories by which we can design messages, the ways people interpret messages they encounter in their everyday lives that are health-related, in the media, through the new technologies, in our everyday conversations. And so one of the key points that I have tried to put out as I talk to people about health communication, and this is a terribly oversimplistic representation, but I talk about mediated communication and interpersonal communication, kind of a 2x2 framework of mediated interpersonal by every day. So we have everyday conversations, we encounter the media in everyday activities, and in planned/formal contexts. So we may have planned messages by professionals, or we may be in formal contexts such as in healthcare. And that's a much bigger view of health communication. When you ask where we've come from, I think there was a time in our field when people, if you ask them about health communication, they said, that's doctor-patient communication. Or they said that was public communication campaigns. And those were sort of the two set answers. And of course, what I just described in this 2x2 does not begin to take that all-encompassing view of what is happening with new technologies that does all of this. So I like to consider that all of these kinds of ways that messages, that we hear messages, understand them, interpret them, take meaning from them, that influence our health behavior, our risk behavior, that's what we study. We study that large array, not just the narrow things. And I think it's important that we have begun to incorporate that larger array into our thinking about health communication. So real basics, messages, meanings, socially constructed realities, thing that you say, oh, that's real basic, everybody knows that. No, they don't. And they really have a tremendous appreciation for how that then can help us to understand the populations who are engaging in risk behavior or populations we want to reach with health messages, and how to frame them so that they fit into their worlds. It is not about being culturally sensitive. It is about the messages fitting the realities, getting embedded in the realities of the people we're trying to reach. So that's sort of my basic, where I go with health communication, and hope that we will come upon a joint thinking about this, that within the field, across the field, and with other disciplines, we can represent health communication.
Great. Gary?
You know, one of the things I like about health communication as an area of study is that it draws from all areas of the communication discipline. It builds on our collective wisdom from what we understand about rhetoric, what we understand about persuasion, what we understand about interpersonal relations, what we understand about public relations and campaign communication, what we understand about the use of media, new media, traditional media, what we understand about organizations, what we understand about communication and aging. We tie in all of these different areas and apply them in a very pragmatic field. Basically, health communication is a problem-oriented area of inquiry. We're identifying issues and problems and trying to come up with strategies for improving quality of care, quality of health promotion, quality of health outcomes. And to that extent, I think it's kind of a very heady area of study where we have a tremendous responsibility. If we're going to be providing recommendations to healthcare providers, to people who are seeking healthcare, to people who are developing public health risk communication, crisis communication policy, we better be damn sure we're giving them good recommendations, which means that the evidence that we gather is got to be very tight, got to be very rigorous, it's got to be very complete, and we have to have evidence to base all of our recommendations on. And so I feel a tremendous enthusiasm and excitement for doing health communication inquiry, but I also feel a tremendous sense of responsibility because the recommendations we make are being listened to at the highest levels of government, of organization. In the last 10 years, there's been tremendous change in society in terms of recognition of health communication as a critical area of inquiry, that major healthcare organizations, corporations, government agencies, international bodies are seeking health communication input for determining how they're going to address important social issues. Right now, we're all facing the H1N1 influenza pandemic, and it's a very complicated situation. And they need information. Information is critical for determining the best ways to respond, the best recommendations to give to consumers, the best way to mobilize resources. We need to cooperate with the media so that they're providing the right information. And there's a lot of challenges. Next week I'm going to be part of an expert panel in D.C., international global panel evaluating the way we're communicating globally about the H1N1 flu. And the more we look into it, the more we're not very happy with the way we're covering it. And it's because it's a very complicated issue. There's a lot of, and the information is changing. We don't know what's happening. We need cooperation from so many different people in coordinating ways that we can deliver a vaccine and the recommendations we can make. We weren't really sure about what the outcomes were going to be or how people were going to react. And we're learning some of that now. So right now on the fly, we need to be gathering epidemiological data about what's going on, who's getting the flu, what effect is it having on them? What seems to be working? What's not working? How is the vaccination effort going? How's the prevention effort going? How's the response effort going? Because the way we deal with this now is going to direct us for the future. This is not the last major international health threat that we're going to face, but it's going to be a defining one in determining how we react in the future. And health communication scholars, I believe, will have a major role in determining public policy and practices for dealing with these problems, for minimizing death and suffering. And if we don't do a good job, it's going to really have a very serious negative impact. And if we do a good job, I think it's going to help a lot of people. So it's an exciting time to study health communication, but it's also a time when we need to be extremely careful and rigorous about the way we do our work and the way we share our work.
Sorry.
I wanted to tag on something that Gary said and take it in a slightly different direction about the feeling of responsibility and getting it right. And I don't think there are any of my former students in the room, but they would say, oh yeah, she tells us that all the time, we got to get it right. And that we're doing research that can make a difference. And I just want to tell this little story. Some of you know I've done some pediatrics research when I was at Karmanos, and we studied parents and children interacting when the kids were having painful cancer treatment procedures. The first time I presented any research out of that work was at the Society of Behavioral Medicine. And, I've always felt this tremendous responsibility for getting it right, but I think that if it was possible to triple or quadruple that, it happened on that day. I was presenting this pediatrics project, and it was preliminary data, and it was on Saturday at the last time session, and everybody's presenting HLM and SEM, and I'm like, why am I here? I've got formative, I've got early data, it's qualitative, and we had a packed room, and just before I began to talk, I heard a woman in front of me look at the program and say, who's in the room? That's the one I came to hear. And I'm going, oh my goodness, that's my presentation, because I wasn't familiar with the audience of this association. So I presented the data. People were, very interested. Lots of questions afterwards to my presentation. And what I discovered was, as people came walking up, was that there were at least 4 pediatric oncology nurses in the room who had come out on Saturday morning to hear this presentation to try to improve what they were doing in treatment rooms with kids. And so we have subsequently published that research, and publishing it, I was very aware, you think, oh, you're building a larger research program, you're answering a question that's out there somewhere, but the first piece that comes out starts to affect people's practice. So if we get it wrong, and I told my coders, because I had one coder who wanted to be nice and give in, and I said, no, let's talk this through. Let's make sure we understand our coding system. It's very important that we get this right, because people will practice what we tell them on the basis of this finding. And I think that's probably true of any number of studies that are published in health communication. We need to be very cognizant of that responsibility. And I think, as Gary says, it's a very exciting time to be doing health communication research, but it does carry a great deal of responsibility with it.
So we've got a little bit of distinctions here. We've got some pretty compelling stories about the importance of what we do. But one of the follow-up questions that I have, and this is something I think I get a little, I feel challenged by, I will say, is when people say, well, health communication is just a context. Now, so I'm going to ask you, just as a follow-up, just a context. So I would say true or false for you all. And maybe
I'll say something as that, yeah. And I think that the answer to that question is embedded in the roots of the discipline and the challenges that we're having right now. Yes, it is a context, and it's much more than a context. Just to link it to the roots of where health communication has come from, and that is health communication grew out of a very parochial, provincial discipline of from my point of view. If you're just taking a look at the communication as a social science. And Gary and Becky and I are aware of what was going on in the 1970s, and there was a core group of scholars, and divisions were formed, so all these things are interesting. But one of the key contributions of health communication was to make it much more than just studying in a context. It took a transactional process, whether it's studying messages or studying physician-patient interaction, relationships, and those things. And to me, it put a dependent measure to it. It put an exogenous variable. We were studying something that mattered. It took the discipline of communication. Only a couple other groups of scholars did this out of and I'll be real crude, studying college sophomores and their inability to speak in public or something like that, okay? And began asking extremely important questions that were grounded in theory. And these theories, is how I would respond to the context notion, are theories that are not just contextually related. They have much broader importance about human behavior and about structural behaviors, about organizational behaviors, about status and stereotypes and those kind of things. If we were just a context, then we would be more like public health. And then we would be more like things that are happening in medical schools that I'm much more aware of, and VA hospitals and things like that. So I don't know if that's the beginning of the answer to the theory, the roots, and those kind of things.
The truth is that it's many contexts. It's a range of different contexts, and those contexts are extremely complex. The hospital or healthcare center or clinic as a context is an extremely complicated one. There's a lot of different people. There's a lot of different perspectives. There's technology. There's policy. There's a lot going on from a communication perspective. To get a handle on that takes a great deal of sophistication. If you move it up to a higher level, when you're looking at within communities, the delivery of health, or even within the family, the delivery of health, it's very complex. There's a lot of different issues going on. While it's studying a context, it's studying those contexts in a way that really tries to pick out what are the different pieces, what are the different processes, and then how can we influence them to improve the accuracy and quality of information and support to allow us to promote health. One of the things I really like about studying health communication is that it gives me connection to many different disciplines. On a regular basis, I work with physicians, I work with nurses, I work with therapists, I work with mental health experts, I work with biologists, I work with chemists, I work with physicists, I work with epidemiologists, I work with other social scientists. And all those people have direct connection to the kind of work I'm doing. All of them recognize how important communication is as well, but they really feel vulnerable because they don't have the understanding and expertise. And they look to me and my colleagues to help fill that void. So I think we play a really important role within this large, complicated social system. And then when you start thinking about the political implications, right now we're in the midst of a major national health reform in the United States. It's really exciting, but it's also kind of scary because we don't know how that's going to roll out. And one of the big things about reform is that we have to actually implement that in a meaningful and humane way that will allow people to access care. The policies in and of themselves won't really change the quality of care, but it will be that implementation. For example, right now we have a really big push for the development of new electronic health information systems, patient health records and portals, and there's great optimism. But if those systems are not developed in a way that people can understand them, can utilize them, feel comfortable with them, that can preserve their information, preserve their privacy, enable them to use them in ways that they can use that information, it'll be an exercise in futility. And we've got a long history of developing technologies that nobody knows how to use, or nobody wants to use, or feel terribly bruised by using them. So it's really important for the communication scholars to say, let's develop these technologies in ways that serve all the different audiences that need them, and invest in them so these people have their say and are empowered by those technologies.
Did you want to add something?
Yeah, I would just add on two things, and my answer to that question about context would be that it's hard for me to think of a context that doesn't have a health and risk component to it. So I have trouble with context. We can talk about many contexts, and each one is pretty complex. And I think, as I continue doing work, I get even greater appreciation with every project of the complexity of the context and the roles that communication plays in those. For example, we were talking about hospitals, and you went up in terms of layers to the administrative, the policy making, and so on. And if you go down back into the clinic, it's not about doctor-patient anymore. It is that, but it's much more like our pediatrics project. We talk about the parents communicating with the kids. Some of the research that Susan Egley has done looks at the companions communicating and asking questions of the oncologist. Turns out they ask a lot more questions than the patients do. And all of that's part of the interpersonal communication that's occurring in clinical settings. And I think you can take every single context that in which health and risk is not even necessarily a topic, but is being influenced by, and you will find tremendous amount of complexity there. So I think there is so much to be done, and the appreciation of the whole world of what this is implies health across many contexts from my point of view.
Okay, so we've just to go back just a second to some pivotal moments, do you think, in terms of the trajectory and development? Because I think you sort of, where we're talking about that, but just, do you think there are some pivotal moments? Like one of the things I think about recently is the Healthy People 2010. Becky was I mean, they have health communication goals for the nation. I mean, that's a pivotal moment. Are there other pivotal
Well, Healthy
moments?
Communication 2020 is going to be even better because health communication is going to be embedded in every piece of it. It's not just going to be a chapter, but every single chapter in Healthy People 2020 has to examine the health communication and health information technology implications. That's the challenge. So, it went from Healthy People 2000, where health communication was just alluded to 2010, where it became a major chapter, to 2020, where it's embedded across everything that we do in terms of healthcare. And I think that illustrates the growth and influence of this field. I think some of the other pivotal issues that occurred were the development of health communication units across different government agencies, both in the U.S. and also internationally. And there's been a lot of influence on health communication agencies like the Centers for Disease Control. Even though the Center for Health Marketing has been reintegrated back into the center, it's not going to disappear because it's also going to be embedded across. And there's lots of communication activity. More and more, as I work with folks from the CDC, they recognize their job. One of their primary jobs is communicating with the public, communicating with healthcare providers, communicating with departments of public health. Even internationally, the World Health Organization, I had meetings with them not too long ago in Geneva, and they were very excited about health communication and are doing a lot of work to develop international communication systems. And so I think that there's some really interesting things that are happening where health communication, when we first started this work, in the 70s and 80s, I remember meeting with medical school deans trying to get them to adopt courses in health communication. And they would smile at me very paternalistically and say, "Isn't that nice? That communication is really lovely, but we really don't have time for that. We're studying physiology and chemistry. Maybe you can do something in the summer, Now, all of the major medical associations are championing health communication. They're making believe they discovered the field. It's really changed in a very dramatic way. The American Association of Colleges of Medicine now requires courses in health communication. They have to have outcome testing. That doesn't mean they're doing it particularly well, but they're doing it. And I think that it's a real sea change. So in many ways, we've become legitimized as scholars. And I think the challenge is, can we step up to the plate? Can we really meet the expectations? And can we provide the information folks want? Sometimes the expectations are unrealistic. Some of the organizations I work with think that I can give them a magic bullet message that will change health behavior, entrenched, culturally regulated behaviors that have been developed over 50 years overnight. I can say the magic words, abracadabra, and people will stop smoking, they will change their diet, they will engage in exercise, they'll take their medications. And so there's a process of education. Wait a second, it really doesn't work like that. It's a longer, more complex process, but there are things we can do. But there is a growing appreciation of the role of communication. Our opportunity is to help people recognize the complexity and help compose the processes to really institute change.
Becky, you want to say something?
Yeah. How many of you know what 2010 and 2020 Healthy People is? Okay, lots of you. How many of you have seen the 2020 objectives? Yeah, they're pretty exciting. I don't know how many are going to be retained. The report is being circulated around the country for comment. And so the objectives from 2010, some of them have been retained and reframed. A couple have been archived, which I don't quite understand, as having already been met. Increase the proportion of health communication activities that include research and evaluation. I'm not sure. Yeah, we increased it, but I don't know by how much. I don't know how that decision making went. But I was excited to look at these and see some new areas being touched upon, because my take initially on the 2010 was that it was a little overloaded on technology and internet. And let me just tell you a couple of the things that are in 2020. Increase the proportion of persons who report that their health care providers always involved them in decisions about their health care as much as they wanted. Now, whether that's realistic or not, or we can figure out a way to measure it or not, I'm happy to see that conversation occurring. Here's another one. Increase the proportion of adults who report having social support. I was just amazed to see that there. Now, what's going to happen with that, I don't know, but it's become part of the conversation. And I won't read the others to you, but there are some total of 12, and I would encourage you to look at that report. And it's out for public comment, so you have the opportunity to reply to it and have input.
How do you access it?
Just Google Healthy People 2020. You will find it on the net. Yeah.
Cami, let me just.
Sure.
I think there's kind of some macro ways of looking at these kind of key turning points in health communication, and some micro ways of looking at it. By micro, I mean within the discipline of communication. But when I found out, and Gary and Becky have both stated kind of those were huge issues. There are other issues when our own colleagues with communication PhDs were all of a sudden getting grants, large grants from NIH, CDC, the VA, foundation money was coming our way. It didn't used to come our way at all. So it went from $0 to many millions of dollars. And people like Dave Buller and others are now in the 10, 20, $30 million range. My own colleague Michael Hecht is up there. There are other, I think, key. One has to understand also that a PhD in health communication means something now. There are jobs out there. There didn't used to be jobs in health communication. If there were, they were not in communication. Now people are with degrees and other things are kind of, in Oracom are saying, well, I can do health. Those kinds. So that's kind of a little key indicator. There are large centers, whether they are funded or not, in health communication or cancer communication or various of these kinds. I cannot think of a major university that does not have a center that has something to do with health communication or an ingredient like that somewhere. There are a lot of health communication scholars, as had been mentioned, that are being invited to be on interdisciplinary care teams. Down at the ground roots level. Okay, the story I tell about how you've made it as a field, when I first went to graduate school, I was in developmental psychology, and we got the basement of the building. The clinical psychologists were up, they had got the windows. Okay, health communication gets the windows now, and I think that's kind of at least at Penn State. I mean, they were very well, and I'm sure at other places, very well respected. It's not something that, as a matter of fact, it's so well respected. And I think this is another kind of key marker is that we have curricular issues. We have our own curriculum for health communication. It's just not, well, you take the basic course in methods, and you take the basic course in comp theory, and then you take the basic course in something else, and then there is a track that one has to take. And the challenge is, as everyone's saying, is we're so interdisciplinary and transdisciplinary and those kinds of things. How do we even, because every year we have to do a re-curricular, we think again about the curriculum. But those are the kind of markers, I think, that are kind of, the other thing, too, is as a, administration in an organization, a convention, there are 800 members in health communication. In ICA, there's something like 600. I mean, that's huge. Yeah. Okay? That means power. that means when Cammie goes to the meeting, when she sneezes, people are going to, okay, are you happy? Okay.
They always did that for Cammie.
Yeah, that's right. So the
didn't know.
power within the discipline has really changed. And there was a marker, and that was about 10 years ago, when individuals started noticing, oh, you have more than 200 members now? Now it's 400, 500, 600, and kind of organizational communication was going down a bit. So those are some markers.
Yeah, we're 10th in the whole NCA for the number of slots. And actually, 10th doesn't even do us justice because we're right in there with, we're probably third in that little group of people that have 28 to 30 or 32 slots. So we're in, for a young division, really, we have a lot of people. It's another outcome. Okay, let's move forward a little bit. I think we're learning a lot from your wisdom. I think it's true. And I think we've sort of covered some of this, some primary contributions. But is there anything you want to add about primary contributions do you think health communications made to the field? Certainly money. I think that has definitely the grant dollars and some theory.
One of the things I think that's really good about health communication scholarship that I really like is that as we're one of the parts of the discipline that we just don't talk to ourselves. There's a lot of, incestuous, silo-based scholarly communication going on in fields where people are writing for the 3 or 4 other people who do work in their area. In health communication, we publish in many different journals, in many different venues, as well as in popular magazines and newspapers, and we get coverage on the radio and on television. It's one of those areas that is kind of transforming scholarship into practice. It's moving beyond just the academic boundary, and I think that's tremendously exciting. It means that we're bringing communication knowledge to bear on important social issues, which I really think is the measure of success of any academic discipline. But of all the areas of our discipline, and there are other applied areas like political communication and organizational, I think that this is the area where we're probably doing the most good, promoting social justice, addressing inequities, empowering people, transforming practice, improving quality of care, reducing errors. I think that we have potential to do some really good things, and I like the fact that people are not bound by the old rules. The old rule was you could only publish in these 3 journals, and nowadays, that's no longer true. And the truth of the matter is that the journals that we publish in outside of our discipline have more legs. More people pay attention to them, and they're international in scope. I'm not saying that we give up on publishing within our own discipline, but I like the fact that we're bridging beyond. And I think we're having a greater influence because of that. I also like the fact that we're partnering with people from other disciplines and working, as John was saying, on grants with people from other fields and publishing with them. It's very common for me to work with people from a range of different fields and publish my work with physicians and psychologists and publish in their journals as well. And I think that gives us more opportunity. We're not really stuck in one area. We have great potential for growth. And there's a lot of things happening right now in society that I think will challenge us. One of the things that's happening in healthcare is we're moving from a top-down, paternalistic model of healthcare to a more participative, consumer-based model. I'm part of a group, I think I'm the only communication person in this group, started a new society for participative medicine. I wanted them to call it participative health, but they went with medicine. And they have a journal, too, that they put out. The first issue just came out. And it's focusing on how consumers and providers need to work together in the delivery of healthcare, and how physicians and other healthcare providers can now be advisors to consumers who actually are in charge of health. And that's a real big difference. That's not the way healthcare has been delivered. And communication plays a huge role, because if consumers are going to be making the decisions, they better have good information. Yeah. Otherwise, we'll be making things a lot worse. It means that we are going to have to gear up, and we have to address issues like low levels of health literacy, poor access to health information, long-standing prejudices and disparities in the delivery of care. These are all issues that I think communication scholars are really primed to address, but it's going to be a challenge to do that.
Other contributions that Young McGarry mentioned?
I would just add, I think that one of the developments, and it's not a specific contribution, but it is sort of across the board contribution, is that as we've grown and developed and gotten greater acknowledgement and recognition from related health areas, we're now at the table on some important things, and that's going to have some far-reaching implications. I was thinking, as an example, the Institute of Medicine reports. And so there's a health literacy report that communication people were involved in. There's one called Unequal Care that helps us understand the role of communication that occurs in healthcare settings in the continuation of healthcare disparities. There was one that's titled Who Will Keep the Public Healthy, which is about training people in public health for the 21st century. And they laid out competencies for what people in public health should be trained in, and two of those are communication competencies. So we're getting a seat at the table of some important conversations and policy efforts that I think will continue to grow to have implications. For example, the health literacy, we have more funding for health literacy. One of the 2010 objectives was related to health literacy. So the more we're part of that, the more we grow and the more we'll be able to support the kinds of research we do that can help solve, as Gary said, these important health problems.
Yeah, I think there's some major contributions as far as methodology is concerned, too. Mm-hmm. I'm just amazed at what our graduate students at Penn State, the major contributions are design and sampling, I think, especially within the communication discipline. Our students at Penn State, the design of their, whether it's an experiment or even an ethnography or things like that, but the sampling, to me, has been again, it's not all sophomores and freshmen in the basic course anymore. And the problems that are encountered in not only having funding or getting funding so that one can have the proper sample, but actually going into the community, to the organizations, to the nursing homes, to the medicals, wherever you're going, just that knowledge that's being gained methodologically and how to do that kind of work in dealing with real-world problems and issues on either macro or micro level, I think has been a major contribution of health communication scholarship.
I think that's a really good point. In fact, I see that a lot of long-term health communication research programs are now multi-methodological, or multi-phase, recognizing the complexity of the problem, recognizing that you need to get really good, deep, descriptive data to understand what different audiences are doing and how they think and what cultural influences there are on health. And you need to really study carefully the delivery systems and how they work and what the rules and bureaucracies are before you develop interventions. In the past, especially in public health, there's been kind of a focus on addressing the issues quickly, but not particularly well. So the interventions often did not work, and in many cases had boomerang effects, made things worse. There was more focus on speed than there was on evidence. A lot of good intention, but not a lot of data. The communication people are much more audience-focused. We like data. We like to understand what's going on, and then we can build those interventions. We also are doing a lot more formative research, so that we're testing along the time we're doing the intervention, because you're not likely to get it right the first time because of the complexities of the social systems that we're interfacing with. So we're figuring ways that we can adapt and refine over time. We're also getting much better at institutionalizing and sustaining interventions over time, which has been a huge problem. I mean, there's been all this intervention work that went out, did their thing, and left, and then the community was left reeling, like, what happened? Where did they go? And then they're more resistant the next time around. And like chronic disease, most healthcare problems are long-term. I think you have to keep at them over time. You have to have that staying power. One of the methodological interventions I really am excited about is the use of community participative research. Over the last year and a half, I've been working with a local community coalition called the Fairfax County Health Literacy Initiative that surrounds George Mason University, where I am. And it's a collaborative of about 15 different organizations, local hospitals, clinics, the public health department, the public library, senior citizen centers, recreation centers, social service agencies, and me, and my students. And together we're doing all kinds of interesting small-scale interventions, training programs, educational programs, redesigning and developing materials, helping people understand about insurance, figuring out what kinds of media people are most likely to pay attention to, training healthcare providers to do a better job communicating with a diverse, multicultural audience, educating senior citizens so they understand better about chronic diseases. I mean, but I think that kind of thing, at that local level, can really make a big difference. And it's really cool that as communication scholars, we get to work with people who are actually delivering care. And I think there's a lot of opportunity in every one of the communities that we live in to do that type of community-based work.
I think that's a good segue, because I think we've got a good sense of what what the contributions are, and two things I certainly take is the visibility issue and the interdisciplinary piece of it too. And moving from the interdisciplinary stuff into some future things, I want to spend the next 10 minutes just talking about what you see happening for us in the next 5 years and beyond. One of the things that I see, maybe you can sort of comment on this too, is the creation of centers, yes, but centers for translational science. And so this idea of, what the key role that we can play in the larger spectrum is this translation, dissemination piece, and partnering with these folks. And what role? I mean, how do these partnerships happen? What role should we play? Give us a good, 2 cents on that. John, you want to start us off?
Yeah, I think that's an excellent point Cammie's making, these and it goes back to what contribution has health communication made to the discipline of communication, because I think we are fundamentally translational. So when the translational kind of surfing wave started going about 5 or 6 years ago, we were poised to get on board with that. And every university, again, that wanted any kind of funding looked at that, and they're writing translational grants, and our names are all over. Our names being in the communication discipline are probably on a lot of these center grants and those kind of things. Let me just say that this is my experiences have been at places like the University of Oklahoma, California, Santa Barbara, Penn State, where the medical schools and where the health research is doing is separate from the colleges of liberal arts or colleges of communication, wherever we're typically housed. And I know it's true for me, and it's true for my 3 colleagues who are sitting up here and standing with me, that getting yourself into, I like what Becky said, you got to get to the table. Somehow you've got to get in that room. And you've got to get off your butt and leave wherever you are. And for us, it's either driving down to Hershey, which is 100 miles away, or going over to the College of Health and Human Development and things like that, and become part of the dialogue. And you have to kind of take some baggage with you that shows that you are part of that dialogue. That process isn't as hard now, because as Gary was stating, the terms health communication have got to be in certain curricula. They're in certain grants. And when you see the proposals for the grants, so we say, well, I'm in that department, or you can do this kind of thing. But I think the hard part is selling yourself, is saying, I'm going to leave my office, and I'm going to actually put myself into a position where my research is going to be read by those individuals who actually can utilize the research. And Gary was very kind to the readership in our journals. Some of you might have seen some panic going on at NCA as far as the readership of the various NCA journals and the citation records and those kind of things. Once you publish in Social Science and Medicine, then you see that, oh my God, there's 30,000 people reading this journal, or the gerontologist from your journals of gerontology, those kind of things. And the final thing I'll say is that research is okay. That research is not only okay, it is, I think, to be placed privileged, which is good news now, because NIH is talking translational, CDC, various different foundations, and maybe at some point our own departments will begin thinking that, when you write a translational piece, which is a bit different, we have to be trained differently, translational research is different, collecting the data is a bit different, that it is quite good, and getting down to the nuts and bolts, you can put it on your Vita. You can, we all know this, having served on promotion and tenure committees, I always get a big kick out of some of the most famous people on our campus on the VITAS list, interviewed by, Oprah, all the different kind of, I used to think, what an idiot, what are you putting that in you would never put that in your Vita, that you wrote a book that sold 4 million copies and helped individuals whatever it's not really a self-help book, it's based on empirical evidence, but it's good translational research. Now I think that should be privileged. So my quick answer to Cammie's question is, get out of your office and whatever thing and go across campus and get involved in research teams in these translational research centers.
I have a colleague who always says, Cammie, get out of the building. You need to get out of the building to do research. I won't tell you who. Becky, you have some?
Well, it's just a theme here, I think, is get out of the office, join your other colleagues across campus, because it is about transdisciplinary research.
In the community.
And get out into communities. And, it's interesting if you go back to our conversation about context. What we do is we go out to the context where people are experiencing the problems. That's what I think Gary's saying. We have to understand them the way they are experiencing them. And that may take you many places. It will take you places you otherwise wouldn't go. It's taking me to Montana periodically, to a little community. And that's certainly not where I envisioned my research going 10 years ago. And so I think getting out of the office, interacting with, at our campus, they're starting a College of Public Health. We have a nice situation where our provost is pushing health across the curriculum. So he's actually facilitating that kind of dialogue. That's good for us, but on many campuses that doesn't happen, so you have to really reach out to make those connections, and I think you'll find people welcoming your participation.
Now, I think the big challenge for the future for this field is that we're going to really need to develop the ability to advise large-scale public policy, which is not something that we've done in the past. Just in the past several years, I've had more and more opportunity to advise major multinational healthcare corporations, pharmaceutical companies, insurance companies, big healthcare providers, government agencies, international agencies. It's it's always really exciting, but it's also pretty scary. What am I going to tell these people? I mean, I it's a kind of level that I haven't operated on in the past, and I'm trying to gear up and strengthen my skills so that I provide good information. I always find, interestingly, even when I'm really nervous about coming into those environments, once I'm at the table and we're talking about the issues, that the kind of expertise that I have and the knowledge I have and the theories I have and the research that I've done really informs a lot of the issues that they're dealing with. And nobody else is giving that perspective. And so a lot of times through the interaction, I find more often than not I'm becoming one of the opinion leaders where I didn't even know that I deserved to be in the room. But I think something about our background and the kind of work we do gives us certain insights, maybe into the human condition, into cooperation, into coordinating, into utilizing different media, to the way we use messages, to understanding the influences of culture. But these kinds of issues come up on a regular basis, and I think this is going to happen more and more. In the last several years, the pharmaceutical industry in particular has discovered communication. I work with 5 different big pharmaceutical companies now. I never worked with them. I didn't like them. I didn't want to work with them. But now I like them. Actually, I find out they're not so bad. It's the insurance companies I don't like.
Gary's our insider for health communication.
But but it's very interesting because they have a lot of influence, and they're dealing with some issues that are really important to us. Issues like why are people not taking their medication? What is it they're not understanding? How effective is the process of informed consent? And those are really interesting, relevant communication issues that we can help address.
So I have a final question for you. I want you to each take just 1 minute because I want to open it up for questions. And 5 years from now, we'll end appropriately. 5 years from now, where should we be? What do you think?
Well, we need more comprehensive graduate programs in health communication. Everything we've talked about suggests that our discipline, this is not a passing thing. It isn't, it was hot for a while. It's growing. The demand is there not just within communication departments, but in schools of public health, in medical schools, in schools of pharmacy, because they do have these accreditation requirements to do training in communication. And frankly, we are not training enough people at a high level in health communication right now to meet the need. Nature abhors a vacuum. That means other people who have either a little communication background or a little health background, public health background, and can say, oh, I can do health communication. You know, it's the old thing of if you talked when you were 2, you communicated, you could be a communication expert. So, I mean, I really want to make a plug, not just for more schools claiming to have health communication, but to have really comprehensive programs, multiple people, as you said, tracks, a real focus on health communication. We need more of that, and I hope we see that in the next 5 years.
That's a really good point. That was part of the motivation at George Mason. Over the last 5-6 years, we've been developing comprehensive graduate programs at the master's and doctoral level, focusing on health and strategic communication. We have a really well-developed curriculum, and our graduate students work with us. We have 4 different research centers that focus on different health-related issues, and students are research assistants on all of those centers and are meeting with us with major healthcare systems and working with government agencies and getting those kinds of experiences. So when they come out, they're ready to go and to work for different government agencies, for healthcare research firms. They're not just training to become communication professors. And I think that's the future, that we have to become broader in terms of our focus and encouraging people to go out and work within the field, to do postdocs at different places, to really learn, to work within healthcare delivery systems. I think there are tremendous opportunities. And the people from our field who have made that bridge, who've gone out to government agencies, have had tremendous sway, have had tremendous influence, have really changed the way these federal agencies and sometimes state agencies operate. And I think that's very healthy. But Becky's right. We really need to be able to train people to do that competently.
Yeah, I see exponential growth. I mean, the one thing that we've done is we've produced quality graduates. And I'm just, as Gary said, unbelievably impressed by the quality of our education and curriculum compared to individuals that have kind of, public health degrees and these kind of things. So I just absolutely optimistic about, 5 years from now we'll be much more involved. Everything will be much better. Grants, getting more grants, more people, as everyone said, in better situations. Those kind of.
Great, thanks. Questions from you all? Yeah, go ahead. Yes, you.
Thank you for support. Can I ask a question, track back to the very beginning in terms of how we set up the folder for health communication? This is an extremely important question for people like me as a doctoral student when I want to make the decision whether I want to evolve into this very exciting and important field. For some of the health issues, which is highly agreed among the experts or healthcare workers, such as smoking is bad and we need healthy diet. And for those questions, for those health issues, we don't have to worry too much about what we are going to say because it's kind of settled and sometimes it's common sense. So we can simply focus on how we are going to say it. But for some of the other health issues, which is highly debated and which is disagreed among the experts, such as H1N1. That's a project I have been involved recently, and I'm so frustrated because I have to decide how much and whether I want to be involved into the decision-making process about in terms of what we are going to say and which message we are going to select to expose to the public. How much we want to help the public with some health decision when we are not as good as the expert, and they disagree with each other, right? So that's the question for me, and that's a big challenge. On the other hand, if I decide not to involve into the decision-making process when there's a debate, then are we going to define ourselves only as a group of people providing strategies? Are we going to identify ourselves only as an approach? If so, how can I distinguish myself from the other people doing public relations in general? How can I distinguish myself with people doing outcome?
I actually have one comment, and I heard this from a colleague recently, that somebody said to her that we don't really want always. We want to respect social marketing and public relations. Clearly, there's a clear role in what we do. But people who are interested in, PR folks are interested in branding. And we're interested in a behavioral response. And what it takes to get there is kind of a different deal. So, and I think that's an important thing to remember. I think what the outcome that we're interested in is sometimes different. So how can you solve the dilemma here, wisdom providers?
John, you're wise.
When you were talking, I would say that you believe the science. You were saying, this is what I picked up a little bit. What question to ask or what strategy to take, and those are empirical questions that have answers to them. And you're well enough trained to be able to, it's not going to be a quick project, but get some money, design a good project, come up with what you can do to suggest in with a team of chemists and researchers and all these other individuals. This would be the strategy that will work because it's been empirically tested for this target population kind of a thing. Look but that's what I go back to is you're a trained scientist, believe in the science, just as the other individuals are. The example I'll use very quickly was my colleague Rachel Smith works in Africa on different projects. They know how to get to let's say, not cure malaria, but get it down so the kids don't get malaria. They don't have the communication background. She's there to show them the scientists, the individuals who know how to implement the strategy that's going to work, and speaks their language because she's a trained scientist, that kind of thing. So be at the table. You have something important to say, and you can have empirical evidence to suggest what is the appropriate messages and strategies. So you're part of that research team, equal partner. Does that help at all?
A question? Go ahead.
Yeah, let me take a stab too, because I think what you've identified is a central sort of division. I'm at the Centers for Disease Control and Prevention, and right now leading the emergency work around H1N1. The question that you've asked is very much the division, I think, between the health campaign groups at CDC who take their very well-researched studies and plan campaigns over for a period of time with resources and careful planning to use what they know in order to translate science, which has a definite answer. It's a very different kind of work than being at the table in the middle of the H1N1 event, where we have one communication person in the room, and we have epidemiologists and laboratorians and so forth, and together we are trying to decide what to do in the midst of, as you say, a situation in which there are not known answers. There are dilemmas, there are things going well, there are things going not so well, there are things we're trying to accomplish, and communication is a part of that, but in order to engage around the table and toss the communication piece in, you have to be willing to go beyond what you know. You have to be able to say, yes, well, in this circumstance, this research found this. This is not the same, but it may have some implications. And so there really is a question there that not everybody is willing to sort of do the communication work without having, all of the research behind them. Those folks do very well with, really good health promotion campaigns. But there is also a place at the table for communication where you really have to be willing to sort of do the best you can with the information you have without being able to say for sure this is how this is going to work.
Yeah.
In the area of e-health records and e-health literacy, you don't hear a lot about the digital divide anymore, but you hear a lot about e-health records share in some regard? Is that, are we doing better? Are we getting further? I know you had an e-health issue recently, and sort of what you see that's terrific is happening and what is terrible or challenging that's happening in this arena.
Yeah, the digital divide is reducing rapidly. It's probably online information is probably one of the fastest diffusing communication technologies of all time. It doesn't mean there's no longer a divide. The demand for access, particularly for young people, is extremely high. And we find that even the poorest people will find ways to get online because they want to be part of that dialogue and connected. A lot of the divide now is with elderly people, that older folks are not as keen to utilize computers. And another divide is the access to broadband, fast connections. And a lot of the applications need fast connections. Another part of the divide that is kind of invisible is the design of health information, that it's designed for a fairly well-educated, affluent, white, professional audience, and it doesn't resonate with people who don't fit that group. There's also a divide in terms of who's seeking for health information. Women tend to be much more active seekers of health information than men. Men are not that involved in health decisions. I'm not sure what's going on there. But, in some of the studies on the cancer.gov website, we find that the vast majority of people who are seeking information about prostate cancer are women. So they're not getting the information for themselves. They're getting information for other people, so they're the intermediary. And so we need to encourage men to become more active in seeking information, or we need to help women do a better job of sharing that information with men. But I think the digital divide is narrowing.
I think we have another question. Yeah.
I guess, it's really situated that we have this calling to advise these large public policies, and it just seems to me to be a really high-stakes endeavor. And so I wondered if you could just talk a little bit about some potential consequences that you foresee for maybe our discipline or the field being at the forefront of these conversations, specifically with regard to sort of the traditional understanding of medicine and how you measure progress, works, doesn't work. Since they're searching for the magic bullet or something of that sort, how should our field measure our own progress? Should we articulate it in ways that the public can then hold us to those standards? Do you fear that they're going to lay that on us anyways? And I think this relates exactly to what you were speaking about. When we do decide to speak out and make suggestions, how is that sort of going to reflect on our discipline or our field?
I'll just echo what John said. We need to be speaking out on a basis of evidence. Gary made the point earlier that, and this is my experience in health ed and public health as well, that there's this sense of jump in, solve a problem quickly, without as much regard for evidence or taking the time to develop the evidence. And I know in certain circumstances we have to go with the best we know now without gathering new data. But I think evidence base is really important. I drill into my students first do no harm, because I've sat on grant review panels where somebody said something's better than nothing, and I think that's a dangerous position. So the short answer is I think evidence based.
I think we really have to work to maintain our credibility, and it's not easy to do. And I think we can make some real blunders that will destroy our credibility quickly, and people will say, well, these guys are jokers. They don't know what they're doing. I'm in a dilemma right now. I've been working for the last 2 years on a big medication adherence research program funded by one of the big pharmaceutical companies. And we've done really in-depth research to find out why it is that people aren't taking their medications and what we could do to help them. We used an information model to try to guide the work. We're at the point now where we want to develop interventions to test them. The giant pharmaceutical company wants to do a large-scale national intervention using direct mail from drug companies, from the drugstores, to people that will tell them what they need to do, and they think that will get them to change their behavior. And I'm trying to argue to them that I don't even think people are going to open these direct mail. No less will, that they need more multi-channel, in-depth, interactive. We need to train people to communicate and to answer questions. And I think if they don't do a sophisticated intervention, they're going to turn around and say, see, I told you these communication people didn't know what they were doing. This didn't work at all. And so I'm in the process of negotiation with them. I'm almost at the point where I'm willing to start doing the intervention work on my own without them to try and get it to work, because I'm really worried that if we don't do it right, it's going to look really bad.
So I think we're out of time now. But I just want to say, when I come to conferences, I think that the most valuable things that I often go to are these kinds of conversations rather than the traditional, here's my data, check it out type of presentation. So I really appreciate the time and the energy and the wisdom here from the three of you, and I learned a lot too. So thank you very much.